Okay. Good morning, everyone, and welcome to the second webinar of the AACDP series titled Community Engagement, Partnership Development, and Care Coordination. My name is Joanna Aalboe, and I'm a Health Program Manager with the Office of Oral Health at the California Department of Public Health and today's moderator. Although we are not in person, I hope you can feel the energy and how honored we are to have an amazing group of panelists sharing their expertise with us today. I'm excited to be working alongside our program organizer, Katie Conklin, and my co-moderator, Dr. Bahar Amanzadeh. Dr. Amanzadeh, I'd like to turn it over to you.
Thank you, Joanna. This is Bahar Amanzadeh. I'm going to be the co-moderator of the day. I'm going to be also a presenter, so I will be changing hats throughout. Great to be here. And Katie?
My name is Katie Conklin. Thank you, everyone, for joining us. It's good to see some familiar faces. And I've been sending you some emails, and I'll be behind the scenes just helping with technology.
Thank you, Katie. Can we have the next slide? By way of an update, the California Department of Public Health, or CDPH, has released the COVID-19 guidance document for dentistry found on the CDPH website under the Guidance tab. The first link shown here is a list of various guidance documents, and the dental guidance is fifth on the list. Or you can use the second link, which will take you directly to the guidance document. This guidance is based on what is currently known about the transmission and severity of COVID-19 and the implications for dental practice. The California Department of Public Health will update this guidance as additional information becomes available. Thank you. Okay, next slide. Okay, let's go over some housekeeping tips. If the entire meeting drops, do not worry and check your email for instructions. The webinar slides and videos will be available on the AACDP website at the link shown there. You can receive 2 continuing education units for each webinar. To receive the CE units, you must complete the course evaluation provided by a URL link at the end of the webinar, and there will be a date to let you know, a deadline. Next slide, please. Okay, we want your participation. We are so glad to have you all here today. We've saved 45 minutes at the end of the webinar for questions and discussion. During the presentations, we encourage you to submit questions to the panelists via the Q&A box. Next slide, please. So when you prepare your questions, if you will give us your name, your organization, and the panelists that you would like the question directed to, followed by the question in the Q&A box. And we would like to make this as interactive as possible, so you can participate by putting thumbs up for questions you like, or maybe that are similar to yours. Next slide. Just to let you know, all participants will be muted to reduce background noise and distractions. If you are experiencing any technical difficulties, if you have any other questions, please send us your SOS to the chat box. And that arrow is showing that one there. And please take note of upcoming webinars. So the next webinar, webinar 3, will be on April 29th from 9 to 11, and it's building a sustainable local oral health program, followed by May 13th and then May 27th. And we'll give you a little reminder at the end again. Okay, next slide. Our focus today is on community engagement, partnership development, and care coordination. Here is our exciting agenda. And the presentations will be followed by a robust panel discussion. Next slide, please. This session's learning objectives are to understand the role of community engagement and partnership development in developing oral health programs, to learn about successful collaborative models, creating systems of care coordination, and to learn how to approach partnering with other organizations. Next slide, please. So with that, I have the honor of introducing our first speaker, Dr. Bahar Amanzadeh. Dr. Amanzadeh is an independent consultant in the field of dental public health and innovation. She is also a member of the California Oral Health Technical Assistance Center at UCSF. She has been working with multiple jurisdictions in conducting oral health needs assessments and community oral health improvement plans, as well as assisting them in developing evaluation plans and implementing strategies through community-based approaches and building sustainable infrastructures. Please welcome Dr. Bahar Amanzadeh.
Thank you so much, Joanna. I really appreciate this opportunity to be able to talk about some of my engagements through community engagement and partnership development while I was designing a care coordination program in Alameda County Department of Public Health. I know these are unprecedented times for all of us, and things are changing. And I believe as a public health practitioner that community engagement and partnership development are actually more important than ever, because we all are realizing we can't do this alone. And so what I'm gonna do is actually I'm gonna go through some frameworks that we used to design Healthy Teeth, Healthy Community programs in Alameda County Department of Public Health. And I will kind of like try to walk you through the story of how it happened, so that I'll bring those basically frameworks down to earth and kind of explain the different components of that through this presentation. Next slide, please. Thank you. So my hope is that by the end of this 20-minute presentation, you will learn about the frameworks and approaches for community engagement and partnership development, and you understand that how different elements of care coordination program can work together. I may not have enough time to go through the details of a care coordination program, but it will go through some of that, and I would be happy to answer more questions during the question and answers at the end. I will also talk about some collaborative approaches that can be applied to your program at the local level. Next, please. Okay, so Healthy Teeth, Healthy Communities program was a part of the DTI. It was funded by Dental Transformation Initiative. It was for the amount of $17.2 million to increase preventive services and continuity of care among 0 to 20 years old children who are on Medi-Cal in Alameda County. The program started in 2018, and it's still going on very strongly. I know that the DTI programs have another year or two to finish, so it's going very strong right now. I was there for the conception of the program, and I was there for the first year to put the infrastructure in place while I was there as the dental health administrator. And the main components of the program are care coordinations and provider engagement. So I will talk a little more about that. Next slide, please. Thank you. This is a visual just to kind of give you an overview of the program. So as we talk about components, you know what's the current status of this program. As you see, the care coordination workforce, kind of creating a county-wide workforce, creating a care coordination data case management system that can be used through different organizations, and then working with the dentists through really engaging them, recruiting them to be part of this program, and having training and contracting with them, and creating some incentives for dentists as way of their contribution. And this way, kind of creating a community of practice through both of these workforce, as well as care coordinators, as well as the dental providers, to increase preventive services and continuity of care. Next slide, please. So the process, how the process worked was that we started the idea development for this grant a year before we applied. So that process started with the design thinking process, which I'm gonna talk a little bit about that in the next few slides. And then we had the grant writing team. The whole grant writing took us 6 months to do that, and we had a very active team that we were working on that together. And the partnership development really started from a year before we got the grant. So it started right from the beginning. The same as the leadership and a stakeholder buy-in, that started from the beginning. For example, Board of Supervisors from the beginning knew that this is what we are planning to do. And the communication with the state, the same way, started from the grant writing process and continues to go as well right now. Next slide, please. So what is design thinking process? So basically the process of design thinking, and some of you might have been exposed to that, is a very iterative process that is focused on the users. You basically look at who is going to benefit from that program and start looking at from that perspective, and kind of challenge some of the fixed ideas that you might have before. Basically challenge the problem and reframe the problem. And from that, you will have more innovative solutions to the problem at hand. In our process, we had the initial idea. So that's the initial idea was that we want to collaboratively design a program that improves the children's oral health in Alameda County and uses community health workers. So that was the initial conception idea. And the rest of it, as well as care coordination and involvement of dentists, came later on. Part of that process is really to have the open, explore, close kind of process. You basically open it up, you brainstorm, and you look at it from different perspectives. You explore different options through having people who are in the group and are really from a diverse background. You explore solutions, and then you look at the ideas that have come up, few ideas that have come up, and you kind of like go back and forth and look at alternatives and compare, and then you come back with one, and you focus on designing that one. As I said, diversity is a big part of any community engagement process, as well as this process. When you have diverse groups, then they're really looking at the problem from a different perspective, and that's where the innovation starts. This process is not linear. That's unlike some other program planning processes, which they start with the objective and they go back. This process is non-linear. They go back and forth, and in order to really explore the ideas and go back to other examples and develop yours more. And it's also very visual. So probably if you have seen pictures of design thinking processes, there's a lot of stickers, there's a lot of mapping going on. So this way people are engaged, they're walking around the room, they're talking to each other, and it kind of brings the visual thinking to the process, which is again kind of invites more innovation in the process. Next slide, please. So we basically, the way we did it, we had what we called a design sprint, and we had a group called Gobi Group, who is, that's their expertise to apply design thinking processes into public health program planning and evaluation. And we, in this design sprint, we were meeting every week or every other week, and we had like six or 7 weeks that we were focusing on these 4 steps: align, inspire, create, do. So when we talk about align, basically that's the phase that you really identify what is it that we're doing. We knew that we wanna conceptualize the ideas for a program, the grant that we were going to apply for, and we had some ideas about what that takes. And we also, we're all there from different community, different perspectives of the community. So we wanted to make sure that we're all working toward the goodness of the community, even though we might have different organizational preferences. So from the get-go, we really did this alignment and making sure that we're aligned on what we're doing. Developing a vision and developing a guiding principles is a big part of any community engagement work that you do. When you look at the different toolkits, they all have it. We decided to do some part of that in the align and another part in the inspire section, so that we can really make sure that we're working toward the same vision. The next phase, when it was inspire, one of the main elements of the inspire mode was that we wanted to look at some other models outside of the field of dental public health, and see what are some models that have worked and what can we learn from them. What are some community health workers models that were working in different areas of the world, and what can we learn from them? And again, in this phase, you really want to go outside of your comfort zone. And even though everybody is impatient to come up with a program and what we're going to do and elements of it, it's really important to expand at the beginning and then go back into designing the details. We also looked into our ecosystem. We looked at the roles that different partners play in Alameda County, and if you're looking in something county-wide, how would that change our ecosystem basically in the county? So that was a lot of mapping happening in that phase when we were doing Inspire, mapping of our stakeholders, mapping of what's going on in the county, and who is doing what and how they can contribute to this. Create phase is really the phase that, we generate the key program ideas, you come up with some we came up with 5 prototype at that point, and then we go back and you look at your assets and how you can utilize those. And when it comes to the doing phase, that's when you put your main ideas and you compare and contrast and look at the blind spots, and from them you look at the details and see what is it that really needs to happen. So that's when you really hone in, you come up with one idea, and then you kind of, from what you have learned so far from the process, you also design the details of that program. So I'm hoping this one, even though it's a quick going through this process, gives you an overview of this process that we used. Next slide, please. In our case, we knew that access to care, from the way that the group worked on it, has different elements to it: provider factor, client patient factors, and system factors. And we were committed to, through this program, to actually tackle all 3 aspects of access to care problems. Next slide, please. This is part of our asset mapping. When we were doing asset mapping and looking at shared values and vision, we developed different buckets, right? And we're saying, okay, this is an example of this program. This is in Alameda County. These are the service providers. This is evaluation piece. This is who is outside of Alameda County, and what do we want to bring. This is not an exclusive list. I just brought up some examples for you. But just given what we were looking at, provider, patients, as well as the system, we just wanted to make sure we kind of look at all of these, as well as some other buckets that develop later. And again, any toolkit that you look at for community engagement, you will see that at some point you will have to do some asset mapping and see who brings what, and kind of bring more details on that. Next slide, please. So as a result of that, this is the concept. This is like an overall concept that came out. Basically, we said, okay, we are going to train dental care coordinators. We decided on the care coordination to be big elements of that. And we looked at community health workers kind of programs or FQHCs who have such models and what can we learn from that. We want to rethink places. Where are these people are going to do their work in the community, and how would that look like? And we're going to create connected care through that. Next slide, please. And this is the program framework, basically, the training, from the training to delivery to workforce integration, and what that delivery looks like. Next slide, please. There's some mapping that we were doing, some visual thinking about if we were a patient, what would it take us? Where are we going to go and to receive what we need, basically, to improve the children's oral health. Next slide, please. And so I want to kind of look at the partnership development as part of that. It happened from the beginning. Some were in the design sprint part. Some was brought up later into the grant writing process. And the ongoing communication through in-person meetings as well as phone calls and emails was going on throughout this process. Multiple communications to keep the momentum going, as well as group meetings to bring people on the same page. I think in retrospect, we were looking back at that how important it was to have both group partnership development meetings as well as in-person ones to kind of like create that alignment, basically. Next slide, please. Just to give you a little kind of a snapshot of our collaborative plan, all of QCs in Alameda County were involved, grassroots organizations, all 5 supervisor districts, and collaborating with all the school districts and family resource centers and first 5 centers throughout the county. Next slide. Our budget was 17.2 million, and 57% of that is allocated to community and providers. That also tells you that figure tells you that, you know, from the budget, you can tell a lot about the collaborative nature of the program. You know, I can say that I want to collaborate with you, but I'm not going to put you actually in my grant much. So then when it translates to actual implementation, you're giving mixed messages to people. So this one was really aiming to create ownership that was shared among the partners, 15 plus partners and collaboration within the agency. And the governance structure was also reflecting that, as far as like, you know, having different governance at different levels, leadership, staff, as well as the community. Next slide, please. Cultivating a vision is a big part of any big program that is aiming for system change. And really, we all knew that we are in it for reducing disparities in children's oral health. And that was a big motivator to keep all of us moving. And as I said, creating a collective ownership is also a big part of creating that system change. And also our evaluation was integrated into activities, creating that care coordination platform was a big step into making sure that our care coordinators are getting the data as they're in the field. They're having their own iPads with them, getting the, you know, really working with the community, working with the families, but also getting the data that they need to look at how they're performing and how they can improve their performance. Next slide, please. This is again kind of like summarizing some of that. I'm not going to spend so much time on this, but just to look at that this was a cross-agency workforce, and that by itself brings some a level of complexity, and you know, you want to be ready for that. But at the same time, we knew Alameda County is a complex community, you know, linguistically, culturally is a very diverse community, and we wanted to make sure that we address that. Our community dental care coordinators speak 10 different languages, and they come from, there are 26 of them, and they come from different backgrounds, and they're really invested in that. The training piece and designing that training was also a big part of that process. And again, the web-based care coordination management. Next slide, please. Thank you. Next slide. I'm going to just spend like 1 minute on this. Dental provider engagement is also a big part of that. Whenever you're doing care coordination, you want to bring dental providers into the mix. And bringing also additional local incentives in different ways, family oral health education, data reporting, and continuing education for dentists, which is continuing to happen right now with the collaboration of UCSF, as well as Alameda County and other resources. It's a big part of that incentive. And this way you develop a dental community of practice. This community of practice, they're working with the care coordinators one-on-one, so the new collaboration and new workforce is really being integrated into the practice. Next slide, please. This is a picture of the community of practice convening. Next slide, please. So they were really working close, the community dental care coordinators. Really the community engagement has been in the process, in the design, as well as what they do in the field. Next slide, please. And here they are in action, really being involved in the training, in the planning of it, and in the, you know, what they do in the community and with the families. Next slide, please. Just a snapshot of accomplishments. As I was communicating with Alameda County Department of Public Health, 26 trained and diverse CDCCs, they have reached out so far to about 40,000 families. Out of that, 24,000 dental appointments have been made. Average show rate is about 76%. It's a little different between the CDCCs that work within an FQHC or the ones that work with the private service locations. So far, 145 dental providers have been working with the program. And again, these are between FQHCs and private providers. And 47% of appointments are preventive services and 42% of around oral health evaluation. Next slide, please. Just want to acknowledge people who gave me feedback or their work has been reflected in this. Thank you so much. Next slide. And with that, I want to thank you. And I hope I can answer any questions that you have at the end. Thank you so much.
Thank you, Dr. Amanzadeh. That was an excellent presentation, and I'm looking forward to the questions and the discussion at the end as well. Next, I have the pleasure to introduce Dr. Ariane Terlet. Since 1989, Dr. Terlet has served as the Chief Dental Officer at La Clinica, where she helped expand dental services from 1 dental clinic to 11 sites in Alameda, Contra Costa, and Solano counties. As the Chief Dental Officer, Dr. Terlet is responsible for strategic vision, direction, oversight, and management of dental operations to ensure the alignment of La Clinica's mission. Please welcome Dr. Terlet.
Good morning. Thank you so much. First of all, I guess I would like to thank Dr. Kumar and Dr. Amanzadeh for the invitation to be able to participate and share with you some of my partnerships over the last 35 years of my practicing in a community health center. And also, I guess the other thing that in terms of looking at, before we start this process is, while I'm going to share all the partnerships and all the things we're doing right now, we're going to have to look at how we practice now. We're in a new state of normal. So while we've been able to develop all of these relationships and how we implement care in the community, we're going to have to retool and figure out how we're going to continue to communicate and provide care with all of the current restrictions that are happening right now. So FQHCs, for those people who potentially don't know, are federally qualified health centers. We are funded under a separate grant from the federal government. We have a different rate of reimbursement. We are reimbursed on a visit basis. While many people think that that's a great thing and that we're making a great deal of money in the process, we actually agree to have a sliding fee scale, in which case we do not collect monies for services that are preventative. So it's a balance. In the end, it is much better than fee-for-service Deni-Cal, but we still, all of us still struggle with making ends meet on a good day. So next slide, please. So one of the things to consider when you're looking at partnerships with federally qualified health centers is why do you want to partner with a health center, and why would they want to partner with you? All of us are huge bureaucracies. So in terms of looking at what is the end goal, and looking at how you can help each other out and how you can work together to help each other out to get to a point where we can provide more expanded care in the community by looking at, I do what I do best, you do what you do best, and together we're able to provide a great deal of care. Next slide, please. Okay, so I just decided to go to the end first in terms of looking at what are the ingredients to success. Quite frankly, in terms of these processes, you need to be very flexible. And I'm going to tell you that you need to always think outside of the box. Inside of the box doesn't work. We all have lived there. So in terms of looking at it, basically when you look at all of our clinic sites, we are all at capacity. And so we need to look how we can prepare particular prevention to the community outside of our traditional home sightseeing. Next thing is have a good sense of humor, because right now, especially in a lot of patients, things go right and things go wrong. And I think having a sense of humor is what gets me through every single day. So I think that that's very important. Have patience. Public health is slow. I always tell everybody it's like the tortoise and the hare, and we're the tortoise. So we will get there. It'll take us a while, but we will get there. So be patient with the processes. For those of you who haven't worked with health centers, we have a whole credentialing, a lot of steps that we have to take for auditing purposes. And so in terms of setting up contracts, it is time consuming. It does take a great deal of time. I will tell you that all of this leads, all these relationships will lead to career and lifelong relationships. You know, when I started doing this, you know, a number of years ago now, you know, I never imagined that the people that I continue to work with, that basically we would still be talking to each other after 35 years. Dr. Jared Fine being one of them. So we've accomplished a great deal when you look back. I count, you know, a meeting one day to have an idea, and then you look at what you're able to do in a community is pretty amazing. Next slide, please. Okay, opportunities. The opportunities that we have is to create more access in the community. Basically, we are able to plan strategically to provide more care throughout the entire communities that we serve, and we can leverage each other's relationships. For example, our working with the counties. The county is able to do certain things that we're not able to do, and we're able to do certain things that the county isn't able to do. A lot of it is because of rules and bureaucracies. One example is that we can bill for services, but the counties cannot. So while the county, in the first grant that I worked with Dr. Fine, it was a Healthy Kids, Healthy Teeth quite a long time ago, is that they had the infrastructure, and they had the infrastructure for the project to go out into the schools, but they didn't have the providers. And I had the providers, but I didn't have the infrastructure. So working together worked really well. And those are the types of things that you look at. The other thing is that when you work together in groups, and in our area, we have, I work in 3 counties, in Alameda, Contra Costa, and Solano counties. We have dental director groups in each of those sites. And so basically we get together now more often than before, but basically we get together every other month and discuss what's going on in the area and in the service areas that we both share, and look at how we can spread and not be competing for the same group of patients in terms of providing all the care to this one group, and then the other 2/3 are still sitting there waiting for other care. So it helps us to have a more even spread. Next slide. Okay, the advantages for, as I talked about it a little bit, the advantages of working with an FQHC is that our rates of reimbursement are different. So we can share and collaborate in that sense, that we're looking at, we get a higher rate of reimbursement to a degree, but basically the other groups can help us with the casework that we don't have reimbursement for. Increasing your networks, looking at what groups of people you work with, whether it's St. Vincent de Paul, looking at any and all groups of people that are providing care, dental care in the community, how we can work together and have linkages. Also, sharing of resources. We've been very successful, I'm going to say, and Bahar talked about this in terms of the grants. When you look at DTI, DTI for Alameda County was actually a pilot that we had done with a number of the community health centers, where we shared a grant and went out into as many schools in our neighborhoods to try and take care of people who are in our immediate working sites, as opposed to just being competitive, one clinic get the whole thing and you're supposed to take care of everybody. It made more sense to split it and have people in your neighborhood taking care of that. So you're able to network, and also in terms of applying for grants, people like community partnerships between community health center and outside resources, and you can also leverage more dollars with respect to how we are working together and spreading the wealth that way. Next slide, please. Educational partnerships. So let me talk to you a little bit about that. So we are very, very fortunate because we are living in the San Francisco Bay Area. We have 2 dental schools just across the bay. And so we've really worked very well with, and in collaboration with the dental schools, of establishing student rotations. So we right now have at our clinic site, we have actually the largest student rotations in the state. I have both UOP and UCSF students rotating through our sites. And this has been great for a number of reasons. One of which is that it exposes the students to a career in public health and understanding what we do in the clinic and understanding that they don't need to go to Fiji to help people when in their backyard there are people who need help. So I think it's been a great source of understanding how what we do, what the access issue is. I have to say that I've seen a tremendous change within the state dental organizations now at meetings and when we discuss things, because so many of the dentists that graduated have rotated through all of their sites that they actually understand the work that we do and what we need and the support that we need. So in terms of that, also the dental hygiene programs, the dental assisting programs, we work with everybody to, first of all, be able to provide more care in the community, but also to give people an experience that basically will hopefully lead to them coming into and working with us at the different communities, in all of our different communities. Next slide, please. So these are, so quite frankly, for me from the beginning. So the other thing too is like working with dental schools, you have more bureaucracies. So, and CODA and a number of things that we have to deal with. So in educational programs, to me, equal workforce. The other thing that's really, I find to be really amazing is that you have young dental students that are training hygienists. You come in and you're coming into our health centers, you're helping us to provide care for these for our patients. But the unintended consequence, if you want to look at it, is that you're also serving for role models for these children to have them look at potentially having careers in our profession. And quite frankly, we have a number of kids that became dental assistants, that became hygienists, and now are dentists. And I think that that's pretty critical. So we work with UCSF, University of the Pacific, Carrington College, Diablo Valley College, and any of the dental assisting programs, including in our area now, Jewish Vocational Services that are trying to develop dental assisting programs, because now statewide and nationally, we have a huge workforce issue since the closure of some of these for-profit dental assisting programs are gone. And the state, the county programs or the junior college programs are very underfunded, and they graduate very few people. I think they're graduating about an average of 18 RDAs, registered dental assistants, a year, and the need is much greater, in particular as we grow and go out into the communities. So but the dental education programs has been, for me, it's our future workforce. It's well worth the time and the investment, because it has paid off in terms of looking at a number of people. Bahar, I remember when she was working on her MPH, also was working with us, and now she's doing this. So I think that that's wonderful. Next slide, please. Okay, so I was going to talk about the alphabet soup. I decided not to put more things in. In terms of working with the health centers, the things that we need to look at is you're going to need to create an MOU, which is a Memorandum of Understanding, and a BAA is a Business Associates Agreement. So we come up with these great ideas, and then compliance comes knocking on our door and said, oh, by the way, you need to do this and you need to do that. It's really important to get these contracts in place and be able to have both sides, both organizations looking at what needs to be done so we can move forward and work. In particular, when you're looking at going out into the community and setting up services outside of the clinic sites, and what we call outside the four walls, basically, it's really important that you have things very well set up, in particular for your doctors in particular, but also for your staff. If you're going to go out and work and develop school-based, these partnerships, and be out in the community and have school-based or screenings that you do, and in particular, if it allowed, these MOUs allow you to be able to bill for services, and more importantly is that for those of us working in a health center, unless you have your own malpractice insurance, your malpractice insurance only covers you within the four walls. So when you go outside, you really need to make sure that they're solid contracts so that our doctors can go out and practice in the schools or wherever they need to be, that their practice coverage follows them, because that isn't always clear. So I think that it's very important to come up with your idea, design it, and then sit down with your administrative people in terms of looking at what is it, how do we set this up, what contracts, what agreements do we need, affiliation agreements do we need between the clinics, you know, and between either if you're working with one clinic or on one site. And the other thing to do is, which I will say, as dental directors, we come up with these great ideas, and sometimes we forget to let the CEOs know what we're doing. So I think it's really important that they know and get looped into this, because we need their blessing in terms of having these partnerships going so forward. So a little word to the wise, I can tell you all the things I've done wrong in my 35 years. So just wanted to share that with you. Okay, can I have the next slide, please? Okay, so associations equal support, equal increased resources, which is really critical. So disclaimer, or I guess my disclaimer is, I will share with you, I'm currently the vice president for the California Dental Association. So I just wanted to want you to know that I wear multiple hats. Organized dentistry is very important to me, but we've also been incredibly successful in California in working very well and very closely with the State Dental Association, and they have supported us tremendously in legislation in terms of legislatively advocacy. Basically the expansion of scope for our dental assistants would not have happened without that support. And I think that they're the access issues, everything that we're doing right now in California has been we've been able to greatly enhance access and everything that we were doing, because we work hand in hand very well with the state association, and they've taken the ball and run with it. So I really, really appreciate everything that, that they've done and continue to do, because we still have a lot more work to do. The California Primary Care Association in your own states, get in touch with your primary care associations. Medicine rules, but you just have to make a lot of noise and know that we are there, and they are also great advocates, in particular when it comes to legislative issues. Bringing back adult dental care in California only happened through the collaboration of the California Dental Association and California Primary Care Association, and all of us making a lot of noise about the importance of bringing back that service. NOAA, which many of you are members, Scott, our next speaker, is very much involved in NOAA. I was actually at the first NOAA meeting. I think it's really important. It's a great resource in terms of helping us try to plan and looking at partnerships. And what's nice about looking at NOAA is that you can see what other groups are doing in other states and how they've partnered differently. We can't all do the same things because the state regulations, dental boards in each state are very different, but it gives you good ideas, and sometimes it's an idea to come and look at how you can change what we're doing and state board regulations within your own state. For us, the other is Community Health Center Network. This is our local networks where we have our sister clinics together. They actually provide the dental directors meeting that we generally have every other month. They're a great resource. We do not just have that meeting open to the clinics that belong to the consortium. This is open to all providers, every person who is providing service to dentistry in the county that is part of the safety net. So it doesn't make sense for us to have meetings, by ourselves talking about the problems that we have, and then you have the county hospital talking about problems that they have, and we're never connecting together in terms of how we can solve it. So we've had very successful relationships with the county, and moving that dial and being able to share what we have, what we're doing, and just giving everybody the heads up on what the needs are. And in these times in particular right now, it's very crucial that we have a good network, and right now we're each other's moral support. And then the county dental health programs. I think that, we've been fortunate, I said, to have Dr. Fine as a champion. It's really important to try to find a champion of dental within your counties and help support them and work together, because we need them to be successful so that we can be successful. Next slide, please. Okay, so in terms of looking at finishing up here, I think that, alone you can do so little, together we can do so much. I was teaching at the dental school my alma mater, UOP, and I love teaching. And it was one of those things where I wanted people to have the experience of coming out to the clinic. And you know, if I go teach at school, I teach a few people. You bring people to the clinics, and then you have a greater experience. So right now, the majority of my staff are faculty at either UOP and UCSF and are part of the teaching program and expanding that. One hand can do, you know, can make bread, but many hands can make a lot of bread. So I think it's really important that you look at how we can get a group of people together and expand our services throughout the community and help share whatever resources whenever we can. I'm going to tell you that it's a little rough in the beginning because while we are collaborating now, we're also competitors in terms of our health centers and our areas. But once you get to the point where you can sit down and just say, look at, this is what we have, this is what we need. The denominator is huge in terms of the patients that we're seeing and the needs in the community. And right now the needs are getting bigger. At our health center, we are now starting to see patients coming in or trying to come in to see us because they no longer have employment and they no longer have insurance. So it's not the general 30% poor that we have. It's happening again. So as it did in 2008, that we're seeing a lot more people trying to provide our services. And I think that we need to really sit back and think of how we are going to provide care to these communities. Our models are all built on us going out in the community and interfacing with all of the patients. And now with the issue of social distancing, I think we're not going to be able to do that. We really have to think about how we can still provide care, but and what, you know, under what setting it's going to be. And I think seriously as dental professionals in terms of partnerships and relationships is that we really need to talk to the medical side of the house, because I think we may be doing more things in terms of medicine. If they come out with a vaccine and it's a successful vaccine, people will need to be vaccinated. And I think we're starting to look at medicine slowly starting to ask us to help them with the COVID testing. So I think that, you know, as I look out and think of all the relationships we built and the models that we have, the models are still good. We still need to continue it, but our service delivery is going to look very different. So I want to thank you so much for the time. I appreciate it. I've gone through this a little bit fast. I hope that this has been informative, and any questions that you have, would be happy to take them. Thank you so much.
Thank you, Dr. Terlet. That was excellent. So remember, if you have any questions, please use the Q&A box and let us know who the panelist is, that you would like to direct your question to, and provide your name and organization if possible. Thank you so much. Next, I'd like to introduce Dr. Scott Wolpin. Dr. Wolpin is the Chief Dental Officer for Eastern Shore Rural Health System on the Eastern Shore of Virginia. Dr. Wolpin serves as a Board of Director member and is immediate past president for the National Network for Oral Health Access. Additionally, Dr. Wolpin is a past president of the Eastern Shore Dental Society and past president of the Association of Clinicians for the Underserved. Please welcome Dr. Wolpin.
Thank you, Joanna. So my charge is to explain why community engagement is so critical to the success and the sustainability of community-based oral health programs. I'm going to share a few of my own personal stories, experiences that hopefully will do just that, validate that community engagement is critically important. Next page. Next slide. Thank you. Community engagement is one of the pillars of the social determinants of health, or the things that make you healthy or not. Another way to think of social determinants are as the cause of the causes of disease. The contribution from the care that we provide to our patients only contributes to about 10% towards long and healthy lives. 30% is credited to genetics, 40% to behavior. And I think you'd agree with me, both of those are extremely challenging ones to move, to improve. The last 20% is related to social determinants. And those are the things that we can do something about. There are things like the environment, the food desert, There are things about things like health policy, who's insured and who has coverage, who has dental benefits. Therefore, if you think about it this way, social determinants have at least twice as much of an impact than the actual care that we provide for our patients. What's even more interesting, I think, is that during this pandemic, the hardest days our country has faced since wartime, that community engagement seems to be at its strongest, even despite social distancing. The current crisis has resulted in people opening up and helping each other. And I see it everywhere. We see car manufacturers building ventilators. We see other industries retooling to create N95 masks or face shields. And we even see church groups sewing masks. What's kind of frustrating, though, is the disparity we see. And I think Dr. Anthony Heighton of Healthy Communities and the California Endowment sums it up quite well when he said, when it comes to your health, your zip code matters more than your genetic code. And we're seeing disparity now with this virus outbreak. The most vulnerable are dying of coronavirus at alarming rates, much higher than others. Why? Maybe it's because we're now counting on people to stay at home, to self-isolate themselves, to wash their hands. But some may not have a home. Some might not even have running water. How do they get the medicines they need to manage their chronic disease? Also, making a giant leap, I think these are the same challenges we face when we're trying to overcome oral health disparities. We ask our patients to do things. You can go to the next slide, sorry about that. We ask our patients, I like this quote from the Institute of Medicine's 2000 report. We ask our patients to do things that they have not done before previously, to stop things that they have been doing for many years. And it is unreasonable to expect that people will change their behavior easily when there's so many forces in the social, cultural, and physical environment that conspire against such change. We've learned this in our own dental offices. Our dental offices have not been the best place to influence oral health behaviors. Just think about it. At our health center, we're tracking how many patients come back with new curious lesions at their recure visits, and I have not been able to really move that metric as much as I've wanted or hoped to. And we're also not very many of us at least, are not trained at motivational interviewing. We really have a difficult time just determining what the health literacy is of our patients. So why should we expect to see improvement when there are these gaps and our patients also come to the office anxious? And yet these are the kind of things that we struggle with in community-based programs. Next slide. However, by partnering and linking with community organizations, we might be able to expand our reach, to earn the trust of our patients, to overcome the obstacles of delivering a cost-effective and preventive oral health care, even for our most vulnerable populations, the ones with the greatest burden of dental disease. But how do we do this? Next slide. Well, I think we have to start by beginning to understand the health needs of our community. I think it's real easy for all of us to do a needs assessment in the community, or in a lot of places they're already existing. But where I think we have a much harder time doing is actually listening to what the community believes it needs most and how we can best serve them. Many times we're just not aware of the perceptions held by the community. And an example I'll share is I was providing school-based dental services in local elementary schools in our service area for many years. But I was wondering what happened to our patients when they moved to middle school, because I wasn't seeing them in our co-located dental medical centers. Many families, it turns out, did not know that their child could continue their care at the elementary school dental units. I didn't know that they didn't know this. And I didn't learn it until I expanded our outreach program into the middle schools. And we found children who once had access care, they had fillings and other evidence that they were connected with oral health previously, but now with new lesions. These children were just falling off the cliff in the continuum of care. Next page, please. Another way to recognize the goals that we're striving for is to stimulate community engagement by initiating a coalition. And I think Dr. Terlet spoke a lot about this. But I think what we need to be doing here is to, again, like she shared, think outside of the box. Go out of your way to invite some unconventional partners, because they're going to bring some very unique skills and resources to you. And it's really helpful to try to identify groups that might be more concerned about the health issues of the folks that you're trying to reach. For example, in my school-based dental program, it was actually the school nurses who championed the oral health prevention program. They were frustrated by the number of children that were attending school every day with tooth pain, and they didn't know how to care for a child that might have been injured on the playground. Next slide. So kind of akin to our patient-centered medical model, I think this is how we need to think about building programs. We need to look at the partners and the champions that will contribute to the health issue that we're trying to address. And so, for example, in my school-based dental program, the unconventional program partners you might think of are faith communities, school nurses, area health education centers, and other professional organizations. Next page, please. So now I'm going to share two stories that I hope really illustrate what community engagement means and why it's so essential. Of course, every story contains a lesson. I served as a dental director for 2 community health centers in 2 different states, and each of them had unique challenges. First, Maryland. There the problem was high rates of early childhood caries, especially for Spanish-speaking families, with many young children attending school with untreated dental caries. Next page. So the innovative solution here was the development of a regional oral health consortium that we called CROC, or the Children's Regional Oral Health Consortium. And the partnership included an area health education center, 2 community hospitals, the University of Maryland Dental School, and 2 FQHCs. And with that group of, we saw increasing returns because we had a very strong and solid consortium. We were able to pursue a grant to open a comprehensive dental center in probably the most urban town on the eastern shore of Maryland, which is very rural in itself. But we also developed a regional hospital outpatient pediatric dental surgery program and opportunities for both student dentists and hygienists to rotate through these community settings. Next page, please. So this is what we were able to do. Well, many of the Spanish families, it was very frustrating, had early childhood caries, and we were trying to connect them with the University of Maryland's pediatric dental program for sedation and comprehensive restorative surgical care. But they had to travel many miles across this very scary Bay Bridge. And as you can imagine, many did not make it. So with this consortium, we were able to pursue our rural health policy outreach grant. And we developed the hospital-based program right close to their home. And I'd like to say that it was a success right from the start, but it wasn't. Initially, this picture of this young child, these are the kind of things that we saw when we first started the program, because we were not doing an especially good job of paying attention to health literacy. You know, we were asking mom and dad to present to the hospital MPO, but nobody really knew what MPO was. And so here's a child that came to the hospital for a surgery eating a donut. When we really started making some great ground is when we utilized the Promotora model. We had somebody from the community that we trained in some basic oral health, and she learned how to navigate the hospital and serve as our case manager. Next slide, please. So let's look at Virginia. Virginia's problem was high-risk pregnant women and Head Start children not accessing oral health care at our own community health center dental program here. Very frustrating. Next slide. Our strategy here was to build a preventative oral health outreach program that we call TOPS, or the Traveling Oral Health Prevention Program. And it's just a very cool, innovative way to bring services to patients that are not coming to us. It's a teledentistry model, and we're using the legislation in our state that permits remote supervision dental hygienists. And so what we're trying to do is create a virtual dental home and provide the preventative care and early intervention services where these patients are, the local Head Start centers, health department, maternity clinics, and hopefully keep them out of our dental offices where the restorative care is provided. Next slide. So this is the little guy in the chair. I hope that's not how you all feel right now, but this was a little guy that we were at a early Head Start who we got at nap time, and we asked him to jump in a chair, and that's how he jumped in the chair. But we'll work anywhere. We're working in closets in schools, and we're just trying to take advantage of an opportune time to provide care to these folks. You know, a good time, maybe to take advantage of a teaching moment. No mother wants their baby to be unhealthy. And all these projects would not be successful without community engagement. All of our partners contributing their unique strengths and mission to the program. Next slide. And wrapping it up, you folks have probably seen this before. This is something that I adapted from Dr. Paul Glassman, but this is our care approach, where we're trying to create, again, a virtual dental home. Many of our patients may never have to come to the office, and that's good for a community-based dental program that has limited capacity. Our dentists are doing the surgery, and our hygienists are out doing the disease prevention and intervention. Next slide, please. We do that with cloudless EHR, the Nomad X-ray unit, and now teledentistry is another way we're doing this. So I think in order to recognize success, you really need to think about disruption, innovation, paradigm shift. And we have to really come out of our silos to collaborate and enable community engagement. Thank you.
Thank you, Dr. Wolpin. That was great. For our final presentation, I'd like to introduce Dr. Alyssa Franzen. Dr. Franzen is the Chief Dental Officer at Care Oregon and serves as the Clinical Director for Care Oregon Dental, Columbia Pacific CCO, and Jackson Care Connect. She leads oral health strategy across the organization with the goal of improving oral health, clinical integration, and access to care for all populations served by Care Oregon. Please welcome Dr. Franzen.
Thank you so much for having me. Really appreciate the invitation and excited to share about some work that we're connected with in local communities. Go ahead to the next slide. Just to touch base a little bit, we really just want to focus on care coordination in follow-up to community-based prevention services. And so really thinking maybe about school-based sealant programs as an example of that, and I'll use that thread throughout the presentation, but it really could be any type of community-based prevention services you might be offering in a very variety of settings. And really also thinking about that follow-up care coordination being part of your system of care when you go out into the community. Next slide. So a little bit of context and background about Oregon really briefly. Our Medicaid system is divided into 15 regional coordinated care organizations. It's essentially our ACO model, but more specifically, dental is sub-delegated through those 15 organizations to 6 managed care plans. And so statewide, we have approximately 6 managed care dental plans. They have been around since the mid-90s when we implemented what was known as Oregon Health Plan at that time, and then moved to the coordinated care model in 2012. There's a very high degree of collaboration between the 6 managed care plans, which is something I think that makes it exciting and unique, and that we really do partner together for community-based services in particular, but on a variety of topics as well. The model for community-based services will vary regionally based on those 6 managed care plans, as well as the CCO, as we call them. And some of those may be that you have community-based programs that are actually offered and operated by the community-based in the community, offered and operated by the dental plan. We have other examples where the dental plans actually get together and fund and operate something collectively on behalf of all of us. We have some communities where the FQHCs or other provider partnerships are providing services in the local communities, and then independent expanded practice dental hygienists that usually have some sort of partnership with a community-based organization, but are essentially functioning under their independent component of their license. Next slide. I think of community-based services in 3 phases, in the sense that there are sort of 3 major buckets that we want to make sure are covered as part of our strategy when we go into the community setting. So the first is really partner engagement, and that's really where your school relationships, your permission slip return rates, classroom strategies, incentives, all of those pieces that really need to happen that sustain your programs and partnerships with your schools before a clinical team shows up. The second piece is actually the service delivery, when your clinical team is there and providing services and risk assessment, and I'll talk about the importance of risk assessment. And then what happens after that team leaves, the follow-up care coordination, and how do you think about follow-up care coordination and communication. Next slide. We really focus on making sure that we're using risk assessment to drive our follow-up care coordination. So I'm going to focus most of the conversation today on that 3rd layer, that 3rd bucket around what happens after the clinical team has left the school, and using some sort of risk assessment to help stratify and define the follow-up components has been really important. Most of the programs that I'm working with are using BSS, and the BSS categories are very broad in the sense that that BSS 1 category has a lot of different clinical situations that fit into it, whereas the BSS 2, the highest level, has a little bit more narrow definition around pain and infection. And I point that out because we have kids that would technically fall into the BSS 1 category, but really do need some care coordination and wraparound services and follow-up. And so we have created a pathway where BSS 1, if it's identified by a hygienist, can also get into qualify for care coordination. So I'll talk a lot about how BSS 2 is really where we focus, but it's also where we can have additional kids that are identified that also need care coordination. We implemented that after our first year, when we really discovered that hygienists who wanted particular kids to receive services were actually upscoring their BSS category. And that has consequences for your population data and some of the work that you do and look at year over year. So we really wanted to make sure to create that pathway. Next slide, please. So we plan for all 3 of the risk categories and what our strategy is going to be. So really thinking in terms of, am I really thinking about care coordination or really follow-up communication, and having a plan for those. So for the most part, a BSS 0 or 1 the lower risk categories may just have some sort of follow-up communication that goes home. You have a mechanism by which you do that, and I'm not going to focus on that part so much today either. You also want to know your care coordination goals. What are you hoping to get out of your care coordination? And then set your methodologies and strategies accordingly. Is your goal just communication back to the family? Is your goal that a kid actually get connected and show up and receive care? And the strategies that you need, as well as the resources that you would need to invest in those 2, would be very different. And so really document what that plan is for your local community program. Know what you're intending and what you need from your care coordination. And that helps when we get into talking a little bit about your community partnerships. It helps for your school to know what they can expect from you as a partner when you show up in their building. And we already talked about the higher level pathways. So next slide. Great. So who does care coordination? And we have seen this all over the board through different programs that we've either looked at or have participated in, but really identifying who is going to be responsible for that care coordination after you leave a school. Here are some examples. We don't have all of these implemented right now. Lists can be left with the school nurse. We saw that maybe 10 years ago much more frequently when we had much more robust school nursing programs in our schools. We've seen those over the years be cut away, and so that is our least preferred mechanism because it really overburdens our school nurses. They are fabulous champions of oral health, but they really just haven't had the capacity to do that kind of follow-up. We have had then where does the organization who's providing on-site services is responsible for some sort of care coordination and follow-up. And so that could be your local FQHC is providing services, a local provider partner, and they may take on then that piece where they take back to their home base and help with some of the follow-up coordination. We've had the individual who's providing the on-site service. So this tends to be the hygienist or dental assistant that's on-site. They may actually be doing the outreach to the families directly from the school. And then I also have one example where we actually have a separate contract for both that first piece that I talked about, where we have in a more rural community, a person that is contracted to really do all of the school engagement, permission slip return. What person was a former teacher in the community, had really great contacts in the school systems. And so he's taken on that piece of the work. A hygiene team comes in, provides the clinical services, and then he comes back and follows that up with the care coordination support. And in that case, our CCO actually has a contract that partially financially supports that component. Next slide. When it comes to contacting the family, you really want to leverage all sources of contact information. So obviously your permission slips and those types of things will have some contact information. But if you run into barriers or snags along the way, really making sure that you've leveraged all possible things that you can. That could be your Head Start team, maybe your school nurse or somebody from the school is connected with that family. Some have patient advocates and caseworkers. And so really wanting to make sure that you think through who else could support you if you have a kid that's in need and you're having a difficult time contacting the family. We also are able to leverage the payer partners. So obviously because of being in the school, but also with a lot of managed care in our environment, the payer partners have been fantastic at really supporting us in making sure that we're able to really work through, apologies, my screen has timed out and I can no longer see anybody. Okay, you can see me now. I can see all of you guys again. But really wanting to make sure that our payer partners have been at the table with their own care coordination teams. They may have information not only about that particular child, but also about the family in general. Next slide, please. All right, and so obviously if you're going to be having some a robust care coordination component to your community-based programs, you also want to have a place for those kids to find and be able to engage in care and in services. And that's a really critical part to your community planning. So wanting to make sure that providers are available, and that is extremely variable, and the model may look very different depending on your community. For us, again, with a lot of managed care and having those partners very much at the table and part of the planning process, implementation and delivery of community-based services, that's one opportunity. But the local provider community is critical. Not every kid that we encounter obviously is Medicaid enrolled. We see some commercially covered kids, of course, a group of uninsured kids. And so really working closely with your FQHC partners, your community clinics, voucher systems for private practices, and local dental societies are all opportunities. and really want to get those folks at the table as part of the planning and early on, so that we're ready to go when we have urgent needs and can find access points in the communities. Next slide, please. And then how are we doing? We do like to track effectiveness of all kinds of things for our community-based programs, but care coordination is one of them, and you might want to think about including some kind of care coordination metrics when you're evaluating your own school-based programs. And so we look at care coordination complete and care coordination closed. There is a distinction. We make a distinction now between those two. One is really when we're able to confirm through a variety of mechanisms if a child actually did show up and receive care that they needed, versus closed in the unfortunate circumstances where we've really exhausted every opportunity that we can think of to connect with a family, and it hasn't resulted in a child connecting with care. And those are sad situations. That isn't our goal, ever our goal. It is the reality, however, of going into schools, and at times we just haven't been successful. Because we're working with a group of payer partners, we also can sometimes validate if kids are showing up in the system through claims, and so that's an additional access point for data that we're able to include. And we set goals for improvement. So really, lots of improvement targets that we have across community-based programs, but including care coordination as part of that as well. Next slide, please. We really want to make sure we understand the community event. So I've really based a lot of this on what might happen in a school-based sealant program, but we also tailor the degree to which we might invest in the care coordination component depending on what sort of event that we're participating in. So for example, we will have a much deeper level of care coordination planned when we go into a Head Start, school-based sealant programs, those types of things. When we go to some kind of specific event that has a targeted population and is with a community partner, we may still do a pretty deep level of follow-up care coordination similar to what we're doing in a school-based sealant program. When you start to get something that's more like a community health fair, we may have no follow-up communication or coordination planned if it's really passing out toothbrushes and those types of things, versus if we're doing on-site screenings or on-site other prevention services, then we might plan something a little bit more robust. So making sure you understand and have a good handle on what your event is may help you think through what sort of care coordination. I neglected to mention earlier, care coordination is can be resource intensive, and so you have to balance out your event and how you leverage your community partnerships in order to support that function of your program. Next slide. And then building the care coordination component into your system of care for community-based services. For us, it's just one of the aspects of going out into the community and providing care that it has to be planned for. I know one of the presenters earlier talked about the BAAs and the LOAs and the contracts, and I can't agree more. That is a really important piece of and able to take forward year after year after year. They of course can be modified to meet the needs of everybody who's at the table, but it's really important way of making sure that everybody's on the same page, and there's a lot of transparency about who's playing what role in your community collaboration. We usually agree to what the principles are going to be and the minimum level of intervention for each care coordination encounter and what those processes are going to be, and we document it as part of our program. And the reporting that I talked about earlier is very transparent. So data is there to help us all improve, and we try to use data as transparently as possible. And then convening partners and stakeholders consistently. And I chose the word consistently very intentionally, because consistently doesn't necessarily mean frequently. And so it may be that with a school partner that you've been with for a long time, that may be just once a year that you need to have some sort of conversation or meeting. And for newer programs that you're just getting started and get off the ground, that could be a much more frequent type of convening and conversations that you're having with partners and stakeholders. But it's a really critical part of building a system of care when you're using community-based service delivery. Next slide. And then for us, very specifically, some things that we're thinking about in the going forward in the future. One is that our risk assessment we're not currently capturing it using the available CDT codes. And that would be, there have been some reasons for that. We have a lot of dental offices that are using the risk-based CDT codes. The criteria would be very different, and we would all then have kids that are tagged with 2 separate CDT codes in our claim systems. We are looking at some analytical ways of separating that and moving forward with implementing, but there are definitely some advantages if there were a way to electronically collect with our claims data risk scores in the community setting. We're also considering moving into some adult programs. Care coordination would look very differently when the person that you're providing services for in a community setting is an adult, and you would be able to bring more of the care coordination components to the visit in the community setting as opposed to a child when the family is not present. And we're also really starting to move into interdisciplinary care coordination and working with our medical and behavioral health counterparts in thinking about cross-discipline care coordination and what are the most effective strategies to move that forward. So I will stop there and hand it back over to Joanna. Thank you for having me.
Thank you all. Wonderful presentations. We'd like to move into the discussion part of the session. If you have not already done so, please use the Q&A box to ask a question. Provide your name if possible, your organization, and your question, and the panelists that the question is intended for. We do have a limited amount of time. We may not get to every question, but we will do the best that we can. And in the end, if we don't get to all of the questions, we could answer them via email if that is helpful. So at this time, I would like to invite all speakers to a panel and start with the first question. I'd like to direct this question to Dr. Amanzadeh. The first question is, although there are various toolkits and resources online, we wonder if there are any tools that you find particularly useful in practice.
Yes, yeah, there are many, if you even just do a Google community engagement toolkits or partnership development toolkits, there are many out there. Like CDC have developed one for HIV, which is very, very comprehensive. Collective Impact Forum has also developed one, very comprehensive as well. Some of the main components of those toolkits, I try to kind of like really bring them up throughout my presentation, but some of the components, like how do you how do you become result-based, right? How do you include evaluation and metrics throughout your program? How do you bring equity into your work? Asset-based, like really doing the mapping and doing your work based on the assets. How do you approach your audience? Like the design thinking really does that, like really looks at it from looking at the audience, approaching audience. So some of these are across the board, like any toolkit that you look at, any good toolkit has those components. Many of our presenters, Dr. Wolpin was also talking about the importance of it and how when you are in the field, what are the components of it that applies. But really capacity building, change management, like really looking at it from like the disruptive thinking and how do you manage the change as you go along? How do you assess it? How do you bring an audience together? All of that are across the board into some of those toolkits I mentioned.
That's excellent. Thank you so much. The next question is for Dr. Wolpin. It's from Laura McEwen from Humboldt County. And she asked, how will your community-based dental services will change with the new COVID-19 challenges?
Oh, wow. I wish I had a crystal ball, but I don't. But I do think there'll be there will be a lot of change, and we just have to see exactly what it looks like. But I imagine that the care we provide will be a little bit different. I mean, we can brush a child's tooth with a toothbrush. Maybe it's more about self-care. Maybe it's a lot more focused on self-management goals and motivational interviewing and using, SDF. But it will be looking different, and it's probably going to cost more. But we need to do the right thing, and sometimes there's good that comes with the bad. So we're just at this point, we're just staying tuned and seeing what's next.
Yeah, that's true. Thank you so much. Okay, the next question is for Dr. Terlet. It's from Dr. J. Kumar. What challenges for the FQHC dental programs to become community champions by going outside the four walls and working in settings like schools?
So you're asking what were the challenges? Yes. The greatest challenge was getting the fire clearances for us to get licensed to practice there, which I thought was hysterical given that all of our children are going to these schools. They've actually eliminated that was part of our getting set up. I think one of the things is that you in terms of going into the schools, you need to go in and spend a lot of time with the teachers, the principals, and talk to the faculty in terms of getting the buy-in from the faculty in terms of us going in. That was the bigger challenge. So over the years, we've been able to establish good relationships. We also have had the issues of where we had a great relationship, great understanding in May, and in June they changed the principal. And so we were in the fall going into the schools, and actually our school-based health centers that are physically located, what we said is that we would have minimal disruption to the classroom. And the principal took that as no disruption to the classroom. So I'm getting phone calls from my staff saying, Dr. Terlet, they won't release the patients to us because until after 3 o'clock. So I'm paying staff from 8 to 3 and they're just sitting there. So I think really having a clear understanding of what it is, what we're going to do, and first the relationships of getting the schools, getting the MOUs, and working with the different school districts, getting that done, getting your site allocated as an extramural site so that we are able to bill for services going out of there is very important. And then just making sure that we have the paperwork correctly. And we've got it down to a science now, quite frankly. And then as you go into different schools, but it really has a lot to do with my manager, who's the coordinator. Is she goes out and she knows all the principals, she knows all the registration staff. And then I guess the other part is once we get every time we get to a certain point, we go, oh, we're doing great. And then we got to get the permission slip signed. So kids don't take the permission slips home. Parents don't read the permission slips, even when they do. So now we're doing passive consent. And so what we're doing is also putting those papers into the initial school year registration. So we want to catch it right when they're registering for school, and all of us that are parents, I know I've signed a bazillion papers and I haven't read them completely either. I mean, we're not trying to fool anybody, but at least it gets done so that we're able to do the screenings on the children. I think we have it down now. We'll be happy to help anybody that's trying to do this. But I think those were the bigger challenges at the time.
Yeah, that's excellent. I think that's really a tough thing to get the consent forms, and that's really smart to do it when they're already having to do all the other paperwork. Did you have extra difficulties becoming that extramural site?
No, that wasn't what the bigger issue was. As I said, the first school district that we had the biggest problems with is that the fire department was holding the fire clearance hostage because they had asked the school to make some changes and the school hadn't done it. So they go, okay, we'll give this to you once you do what we asked you to do. So sometimes we get involved in some of this little politics stuff, and I'm like, okay, you guys time out, figure this out. And because in the meantime, we're not able to access care. I think the main thing is that going back, for those of you that are in MC, go back to your staff that are in charge of licensing so that you can make sure that they help you get that set up, get it set up with the state. And in particular, as I said, my greatest concern is that your malpractice follows you. So if you're sending people out and you don't have proper agreements, your employees do not have malpractice coverage while they're out there. And I think that that's pretty critical because staff they'll go wherever you ask them to, but it's our responsibility visit to make sure that everybody's properly covered.
That's excellent. Did you have something to add?
Yes, if I may add, I just wanted to bring it to ask Dr. Wolpin as well, just knowing that you're also,
Sure.
as an FQHC, have that experience. If there's anything that you could add to that, also reflecting on role of FQHCs and as dental directors, how do you manage the clinical expectations and the public health, you know, and service in the community and all of that piece?
Yeah, well, I think like we were sharing before, you know, you have to have a good sense of what the needs are in the community, but not only from a, you know, needs assessment perspective, but getting in and talking to people and asking them what their greatest challenges are and concerns. And I think it really makes a huge difference. It's all about relationships. The reason why our school-based program is so successful is we have a person who has a relationship with each one of the principals. And I don't think we do a really good job of telling our story all the time. So what we did is we created like a little value story that my coordinator can bring to various schools. And she talks about the impact it can make in the children's, you know, their academic performance. But it is tough. And I know that I shared with you that I wish that we were more effective than we are, but it's just very challenging. I think when we go back and we look at the children in our school base, I think I saw the question come up on the Q&A. Somebody was wondering, well, what is the caries rate when we're seeing our children on recare visits? And I have not really been able to move it much lower than 40%. And these are high need schools, but it's just been very difficult. But I think as we start employing more tools, you know what I mean? As we get more of our medical colleagues to be part of the solution also, you know, they may be seeing these children at well child checks, and if they can reinforce the message that we're trying to deliver to parents, it might mean a little bit more coming from, you know, the doctor that, hey, this oral health is important in the part of your child's overall health.
Great, thank you so much. So Joanna, do you have another question, or do you want me to handle the next question?
Sure, go ahead. Yeah, that'd be great.
Great. So Dr. Franzen, there are some questions around the care coordination system and the basically the way that you talked about level 1 and level 2. And is there a way to put children in level 1 into care coordination without changing the data that are recorded? In our basic screening survey, we would occasionally mark down different information for follow-up than we would record in our data.
So I think I understood your question. Yes, so we have, so if I don't answer, please let me know. We have a system where we like to keep the BSS scoring, and I know there was a question in the chat, one of the chat boxes about BSS scoring, and we can send out more information on what that is, but it is at a much higher level and not as detailed as a risk assessment tool that you might use in the clinic setting. The ability for, we have just a process where a dental hygienist can keep track of a list of kids who are BSS 1, which most of our programs would be sending a letter home as the major communication strategy for BSS 1. You can have a child that has 4 quadrants of pretty significant decay, but they don't actually meet the criteria for BSS 2. And we still would want that particular child to receive care coordination services, so they get flagged in our care coordination process for follow-up care and essentially added to our care coordination list, which we no longer call our BSS 2 list because that was creating some challenges. What we found was that hygienists were upscoring in order to get a kid on the list, and putting a kid to be identifying a child for care coordination shouldn't be an upscore. It should be what is part of our program and that's the purpose of us being out there.
Great, thank you so much. Great.
Yeah, there's another question related to care coordination. It says, can you discuss if you're using an electronic platform for care coordination and how well it is working for you? And that's just for the panel. Anybody that might be using electronic platform.
Answer that. And for the Alameda County HTHC program, yes, we're using an electronic platform, and designing that platform was a big part of this design of the program, because you want something that manages the data, but at the same time you want something that is easy to use in the field with the care coordinators. Also, in our case, I know there were some questions about the data from the dentist and how do we track a no-show or and other aspects of that. And so we have actually dentists fill out the report forms as well through this electronic platform, so that after each patient, we get that from the dentist too, as far as, and the questions were designed in a form of like, what kind of services, what category of services, was evaluation, was it preventive, was it tertiary care, so that we can see over time how it progresses. So basically from the beginning, when somebody is in the community doing outreach, you have that data all the way to when they see the dentist, when they get referred, when they go to a dentist, and all the way to the end. I don't know if Alyssa, you want to add anything to that, Dr. Franzen?
Okay, I'm unmuted. For us, we are actually not using a particular platform because of having 6 managed care dental plans and 15 coordinated care organizations. We do not have a common platform right now. I will say in our major metropolitan area, where the 6 dental plans have formed a separate nonprofit where we work together collaboratively to provide community-based services. We are looking at moving to something community-based in that setting, where we have all of our enrollment information pooled at one organization, but not so far in the other regions.
Great, thank you so much. Yes. It's interesting, I'm wearing 2 hats right now. So I'm going back to my moderator hat. There was a question about how do we go back after what we are going through with COVID-19 right now. Let's say if you're imagining school-based services after this, or any other services in the community, how do you envision that happening? And this is to all of the panelists. How do you envision our community-based work starting and progressing?
So Bahar, I guess I'll try to answer it first. I think, Governor Newsom yesterday talked about a plan. I think that in terms of looking at what we're going to do, I think it's really going to depend on what happens with how we come back. One of the questions that they were talking about was that one of the suggestions was, because if the point of social distancing is to split the classes up and potentially having a morning session of kids and an afternoon session of kids. I still think the potential for us to see children should be okay once we have the PPE figured out. That's going to be the thing. How are we going to practice? We were looking at providing more delivery of care on site. We may rethink that again, in terms of when can we use a high-speed handpiece, under what conditions, and what are the setups? So I think we all think in our heads, well, maybe this and maybe that, but I think, looking at the local governments and what we're going to be allowed to do, how we can fit into that. And then the question is, what's the fear factor? Because while there are many patients that are ready to come back to see us, there are a number of patients that are really afraid. And in terms of, do I really need to get my teeth cleaned because am I going to get something? That sort of stuff. So we have to make it safe for everybody is my feeling. So I think we all want to come back, and I think, but how that's going to happen, I think we have to see what makes sense, do it right, and not have it be, I'll say, overkill, because us walking in spacesuits is not a happy proposition for these children unless we get some sort of pattern on the spacesuits, So I think we don't know. That's the fuzzy crystal ball, right?
Yes, thank you. Anybody else want to add to that?
Well, I'll jump in for a second. I just am trying to imagine what, oral health looks like in 30 years from now. And I think it's going to look different. I think that the restorative and surgical care that we provide, most of it might be provided in an operating room setting. And just like, when our primary care providers are trying to keep our patients healthy, sometimes our patients don't stay healthy. Sometimes they develop end-stage disease and they need to be seen by a specialist. So I think what will happen maybe over time is that I'm hoping at least that oral health is part of overall primary care health. And, we'll be oral physicians. Dentists can serve in so many ways, just in screening their patients. There is a new test now, a saliva-based test for COVID. It makes sense that dentists would be involved in that. But maybe much further down the line, oral health is kind of part of primary care, and you go to the dentist in an operating room setting if you find yourself with end-stage disease, much like your doctor sending you to the cardiac surgeon when unfortunately we were unable to manage your coronary artery disease.
Thank you.
Kind of out there.
Yes, thank you so much. Yes.
Thank you all that was a really good discussion. I have another question from Miranda Davis for Dr. Wolpin. She asked, is the promotora in Virginia similar to the community health worker? And please talk about the promotora's training and scope.
Well, the promotora is a model, and we did not send this person to a certified training program like a community dental outreach coordinator, or health coordinator. But we modeled a lot of the training that we provided to that person from those types of programs. And so this was just a person who was a member of the community at large, but had some more better understanding of oral health and was able to communicate it in a way that the community could understand it better, the importance, the why it was important for their child to have their teeth fixed. A lot of it, there were a lot of cultural things that we would have never known about if we didn't have this promotora model. A lot of the Spanish-speaking families lived in multi-family dwellings, and we were just pounding our heads, scratching our heads, wondering why the child wasn't changing their feeding habits. Why is the baby coming to the office with the blue stuff in the bottle? After we said, no more blue stuff. But we later found out because of the promotora that mom was trying to be respectful to the other families, the people who had to work the next day. So the baby wouldn't be up all night keeping everybody up. Baby got a bottle with honey on it, or baby got a bottle with something purple in it. So once we knew that, it made a big difference. We told our patients to drink water, but they were afraid of the water. So that didn't work too well either. We didn't know these things until we started working with this person who could communicate with the community a lot better.
Yeah, I could see where that would improve habits and help with just making a plan for improving health literacy. That's excellent. Did you have a question, Dr. Amanzadeh?
No, this was great.
Okay. Yeah. Anybody else have anything to add? Do you use something like a promotora or a health worker?
I could add with the Alameda County model with the HDHC, and there are some questions about care coordination and how do we identify families that need the care in the community. And I think part of that really, as Dr. Wolpin was mentioning, when you are working with people who are rooted in the community and or people who really get trained to do this community-based kind of work, there is some sense of really understanding the needs of the community. We kind of come with that. It's interesting because sometimes it's hard to train somebody to go there. I mean, it's still a skill, but some people really have that. So you have that, and then you put the metrics in as far as if somebody has, in our program, we wanted to increase the participation of families who haven't seen a dentist, children who haven't seen a dentist, at least within the last year, right? So you really look at the risk, like if somebody, I mean, and we're working on a medical program, we wanted to increase the utilization of medical services, right? So we had a criteria developed that we would go through that, right? Kind of like a flow chart, right? And based on that, we would kind of, depending on that, we'll prioritize the services, the care coordination services. That wouldn't mean that if you're going to community outreach event and there's somebody there who wasn't on medical, you would refuse the services to them. You would kind of like take other approaches for that. But still having those criteria would help in kind of like really identifying who is the community that you're reaching out to.
Yeah.
Just want to make a comment about the promotoras that you'd asked. I mean, we work in a health center, and just because we work in a health center doesn't mean that we're not siloed within our organizations. And so one of the things that we did find is that the promotoras are amazing in terms of looking at the cultural competencies and bringing in what are the concerns of the communities at all different times. So one of the things that we have done in the past, and I have to say that we need to do again, is to do a dental training for the promotoras in terms of what is the messaging that we want to give as the dental department. What do we want to tell the community in terms of their actions? Because what we were finding was because people were asking them questions, they were trying to answer them on their own, and it wasn't always the same message that we wanted to have delivered. So we have made a point of trying to work with promotoras and give them, just a good education on oral health and what are the things that you want. And, like Scott says, you've got 10 adults, you're sleeping in a 1-bedroom apartment, and they got to go to work. And so they're going to put a bottle in the baby's mouth. And so I think it's, but it's also trying to help them educationally. As much as we deal with the science of all the science and the healthcare, what I have found the thing to help people not put a bottle in the baby's mouth is the fact that they're paying for diapers. I go, the sooner you stop giving that baby a bottle at night, the sooner they don't have a diaper there. So, and it's like, oh, wait a second, diapers are expensive. So sometimes that's the out of the box thinking. We're so scientifically based, right? But I think that for overall health, but it gets their attention, and then you can work on the oral health aspects of it.
Yeah, I think that's why the model works so well for us. We had this person who lived in the community, but we shared the Smiles for Life curriculum, and she did this on her own. And then she was able to frame it in a way that meant something more to the community than the science. There were more real life solutions and strategies. It was a really neat way to do this.
Thank you. Alyssa, Dr. Franzen, I'm curious about your model and the care coordination, and where do your care coordinators come from as far as the background and their work in the community?
Yeah, the care coordinators, it's variable depending on which community-based program. So the care coordinator, the example I gave where we have a separate contract for care coordination, that person actually was trained as a school teacher and has really good connections in that local community. It's a small, more rural part of the state. The care coordinators then more in our metro area, where our FQHC partners are the ones that are delivering a lot of the services in the community-based locations, are much more housed within the FQHC, and part of our contracting with FQHCs for community-based services, we contract separately for community-based than we do for comprehensive or definitive care. And those contracts and relationships and partnerships actually include the FQHC staffing some of those care coordination responsibilities. And then the one where we have our own separate nonprofit, we also have a couple of internal folks that we staff ourselves and are supported by the dental plans. And then of course the managed care plans all have trained care coordinators. The dental plans tend to have much more robust training in motivational interviewing and some of those skills. And then we try to offer and extend some of those skills to other people in other communities or partnerships that may be supporting care coordination in their local community.
That's so great.
It's a little bit across the board.
It's so great to see that level of partnership between managed care and between different partners and between the state. I think Oregon is a unique model when it comes to that. So thank you for sharing that.
Yep, definitely.
I'd like to ask, while we're on the topic of care coordination, how you involve parents during this care coordination process. For example, identifying care plans, goals, motivation, and even their feedback.
That's a big challenge, I think. When you talk about the parents, we have learned many times before, and also in my own private practice, about, the question, we should involve the parents as much as possible, but my first question is, who takes care of the kids? Because we can talk to the parents, educate the parents, but if it's the grandma or the auntie, I had two of my patients, they're both nurses, and the son this is my private practice, and he kept coming in with cavities, and I kept telling them, let's work on this, we're working it together. And then they go, no, we don't buy the stuff, we don't give it to him. And then finally they go, oh, you know what, it's auntie. Every day she would give him candy. And so that's part of it, is really who's taking care of the child, who's the direct child care giver. Bring that person in and talk to them, with them, and with the parents, because a lot of the parents, they're working to support the families, and so I think that they want their kids to be healthy. They don't want the dental bills either, but I think it's really important to identify who's the primary caregiver to that child and help work with them. And then go from there and educate the whole family. But otherwise, you may be talking to the wrong person.
It's true. There's always so much more to it, right? It's you think you understand the process, and then all these new bits of information come up that are so relevant and make such a big difference. Did you have an added question to that, Dr. Amanzadeh?
I was just reading through my own questions through the chat box, and I just wanted to summarize some of those answers. So I received some questions around challenges and barriers that came up during aligning, designing, grant writing, and implementation of the TI project. By the way, this project is Healthy Teeth, Healthy Communities, was part of the Dental Transformation Initiative that came through Department of Healthcare Services Agency in California. I think it was 2016 when it went out. The application was out, so the challenges and barriers, of course, whenever you're doing any program, especially if you're aiming for system change and you're working with so many different partners, there are challenges. I remember at some point we had this discussion with DHCS and they were saying, like, your application is amazing. It was 120 pages, a piece of art, really. And they're like, it's amazing, but are you sure you want to have these many contractors? Do you know how much it takes to do that? And I said, yes, that's our main goal, to do that. And we know it's not easy. So just wanted to kind of bring it up, basically based on what you're aiming for, your challenges are going to be as big as what you're aiming for, basically. So during aligning, again, the conversations, there were times that we were not aligned with a partner, right? And we have to have those negotiations and those communications. But again, going back to the vision, again, would kind of help us to kind of like do align at the end, right? But there wasn't a partner that we would say that we deleted just because we couldn't align. At the end, we were able to kind of do some negotiations and come back. Grant writing, again, there was so many back and forth with DHCS. We ended up, I think my own negotiations skills improved a lot after that. I mean, the original one was about 16.5. And then when we went back to the state, we actually increased that to 17.2. So we were able to, again, negotiate up. And with the great grant writers that we had at the county as well. And implementation is a harder time. Whenever you're doing any work in the county for anybody, you know, really, you all know, kind of like putting out the agreements, the contracts in place, hiring. This is a new workforce. Like FQHCs had to figure out what category in their own organizations they want to put it in, right? Because you want to establish a workforce that then you can justify and put that in your hairstyle scope of work, so that after 3 years, then it becomes part of your scope and brings some internal sustainability, right? So all of those, again, are challenges, but at the end, they become your biggest solutions at the end when you go through them. So these were just some examples of that.
Could you elaborate a little bit more about incentivizing the community partners to get involved with your program?
Yes, and I will have other people chime in on that too. So the partners were dentists themselves. There were contractors, right? Both FQHCs as well as private dentists. And we had different level of incentivization. First, there was something because we wanted to incentivize 0 to 5 years old services to 0 to 5 years old, right? So we had to bring like UCSF in, we had to bring develop some CEs so that those dentists actually get trainings, and that was part of the incentives, so that they were more comfortable working with 0 to 5 years old or children in general, right? Mm-hmm. Another layer of incentivizing was monitoring, right? So, you know, there's a lot of, as you heard, there was a lot of reporting going on. There's a lot of, you know, many people, many dentists were not used to do all of that. So even though it wasn't much, but per report, we would add an incentive to that, right? So that they feel like there is an incentive to that. And, you know, working with other community partners, incentivizing is not always monetary. You know, sometimes when you have partners you have around the room, you listen, you incorporate that into your program and you work together, that engagement by itself is an incentive. And that's, I think that's basically the spirit of collaboration. So you can look at this, but it's always good to look at that from that lens of what is it in it for the other person, right? Mm-hmm. I don't know if anybody else wants to add to that.
So, Bahar, yeah, I think the monetary consideration helps us sell the programs to our CFOs and our CEOs in terms of that. So I think that, and free CE is wonderful for all of us that need continuing education classes, in particular people in public health. So I think that just because of cost, but I think one of the things that we found in this is that you need to pay attention to if you are an FQHC is that any monetary, and it needs to come in as an enhancement to the PPS rate, because initially what we found is because the ways the laws are written is and I'm going to make up the numbers, if the incentive is $25 a visit and I'm getting paid $100 a visit by the PPS rate, well, my expectation is I am now going to make $125 a visit, whereas what was being looked at as the state was, no, now we only have to pay you $75 and the additional $25, and then the $25 you get from the site. So that did come up. So I think it's two things. On the state level, that was taken care of, but you need to also make sure whatever your county contracts are, that understand that this is going to be an enhancement to the rate and not just basically how you make up, you know, how to pay less the other way around. So I think those are the things in contracts, and it's not until you get into that you go, wait a second, the math isn't right here. So I think that just to pay attention to that.
Thank you.
Yeah, that's good advice. Anyone else want to add to that? I think we can sneak in one more question. And this comes from Laura McEwen from Humboldt County. This question was for Dr. Amanzadeh. Since your target was children up to age 20, did you get many general dentists who did not want to participate because their focus is generally on adults?
Yes, definitely. Again, kind of bringing those trainings in, having those conversations. So we had different targets when it came to the providers. There were some that they have worked with us throughout different programs, and we knew they are gonna work with us again. Then they will look at the map of the county. There are areas that we know we needed more providers and we needed to do more of hardcore outreach. And Dr. Fine the provider consultant on Alameda County project. So a lot of like one-on-one meeting with those dentists and talking about what does it take, you know, what are their needs, how can we help them to get on that, especially with the private providers, that that was necessary to have some of those conversations. But yeah, this is, you know, when you are working with providers, just looking at where they come from and how can you work with them and look at their needs and bring them on. And you know, sometimes we had some providers who were not medical providers, and we wanted to convince them to join medical program, right? And that's another layer of work. And there were one provider that there was this story that would say, you know, no, I had this dream that I opened my doors and the school bus came in and my practice was flooded. There's no way I can handle that. And we were like, yeah, you don't need to go all the way there. We'll do one by one, and kind of like do gate openers. So yes, many challenges, and some of them were overcome.
That's excellent. All right. So we're getting close to the end of time, close to the end of the hour. Does anybody have any final words that they'd like to share?
I just wanted to really, on behalf of myself, thank all of the panelists. Such a pleasure to really work with all of you and be on this panel with all of you. I also wanted to give a quick update about Dr. Myron Alukian, you know, who is a founder of AACDP, and he's in the hospital in ICU. Battling this disease. The latest news is that he's doing well. He has been stable. He has been on a ventilator for the last 10 days, but he has been stable, and we hope to hear him back very soon. So yes.
Yeah, sending prayers to him and his family.
Yes.
Okay, well, thank you all. Thank you all for attending. Thank you for the panelists for sharing your time and your expertise. We truly appreciate it, and we are looking forward to our next meeting. It's webinar 3 on Wednesday, April 29th from 9 to 11, and it is building a sustainable local oral health program. So thank you all for attending. Have a wonderful afternoon.
Thank you all.
Thank you.
Thank you.
Thank you so much.
Thank you so much.
Thank you.